Hello and welcome to another Atypical Philosopher video. I am terribly sorry. I mean, my name is Jonathan MS Pierce, for those who don't know me. I'm terribly sorry that we're a couple of minutes late. Not the first time. My computer just froze and had to do a restart, literally as I was pressing go live. So that's typical. Anyway, I'm really excited today, not only to be introducing you to or speaking with, if you know her already, a colleague writer at OnlySky, which is the new media platform for the non-religious, to give voice to and represent the non-religious. So I'm really excited to introduce you to a writing colleague there, but also the subject matter that we'll be talking about today is a kind of new area for me. It's nothing I particularly know an awful lot about. And so that's exciting as well, because this will be an interesting conversation for me as much as hopefully for you guys as well. But anyway, without further ado, please be upstanding for wherever you are in the world for Eve Makoff, Dr. Eve Makoff. Eve, thank you so much for agreeing to come on to speak to us today.
Here.
Excellent. Would you like to give a little bit of an introduction? I suppose if you start where you are now, and then we'll go back to how you got where you are now and what that might tell us about anything.
Sure. It's kind of a messy path, and it's not easily explained because even beyond what I've written about and what is currently on OnlySky and elsewhere, I have a different job. So I'm a medical director over a program that is actually a government program that works, that oversees low-income elderly patients. So it's an amazing, amazing program called the PACE program, which is national, but we have the largest one in California. So it's a very exciting endeavor, but I don't see patients anymore. I oversee doctors. So it's a very different, I've always done some management and some sort of leadership type positions, but I decided it was too hard to do both. So I've now, for the past year, been overseeing other doctors, which is a whole other thing that I will eventually write about.
Right. So you moved from being a doctor working in a hospital in any particular capacity, or, you know, what was your sort of journey through doctoring?
Well, I won't mention every piece of it, but in general, my career since I graduated medical school in 1995 has been in hospitals, in clinics, and in cancer centers. And most recently, I had, and I do write about this a lot because it really, really impacted me. Before this job, I worked for a year during the pandemic doing remote palliative care. So
wow. So, and we're going to be talking about this to some degree later about the kind of personal connections you make through palliative care. But if you then have to say we have to do that remotely, you're saying, well, this is the one thing kind of we want here, and now we're disallowed from doing that. So that must have been quite a challenge.
It was really hard, and I think it was important because we were all they had, but it was so far from ideal that it was almost unmanageable. You know, the feeling of helplessness, like I wanted to be there touching someone, like looking around, you know, examining them. And I did have a nurse in the home, so we did have somebody who was there, but it was a very, very interesting experience.
So talking about both California and palliative care. So one of my favorite bands is James. It's a band from Manchester. You probably won't know them. They're most famously in America most famous in America for their song Laid and their album Laid. But they did a song, their most famous song in the UK is Sit Down, right? And everyone knows the song Sit Down. Oh, sit down next to me. It's like really famous song. So anyway, he's living in Topanga Canyon, the lead singer in California. And with his wife, and his wife's father was dying in hospital in the UK, and they weren't allowed. This is right in the middle of lockdown. They weren't allowed to go to the UK, and basically they had a FaceTime, and literally just as he was just about to die, and he asked if he could sing "Sit Down" to him across that, and it's just really moving. It's a lovely moment, but that spoke to me of the weirdness of the lockdown palliative sort of scenario.
Yeah. Had I been working in the hospital during COVID, either as a hospitalist or as a palliative care physician, I I mean, I've seen friends of mine who did it, and their sort of moral injury and grief is so profound, because not only could they not really get too close to patients, but they had to sit in for family a lot, and they really had to fill so many gaps that palliative care already fills a lot of gaps. And in a way, I feel badly that I wasn't there for that. I mean, I was, the beginning of my training, HIV AIDS was still a big deal. We had a whole, when I was an intern and a resident, a whole floor was basically people with HIV AIDS. And then I sort of lived through H1N1 and had patients with that, but it was nothing. Like when this started, I looked at my hospitalist colleagues, my palliative care, and said, I can't, especially in New York when it first started, I can't imagine how devastating that was.
And it's just really interesting because you mentioned this term moral injury, and that's a term I'd never heard before until I heard it watching like CNN excerpts on YouTube of nurses and doctors in COVID wards talking about the moral injury to themselves. Yeah. And so how would you describe what moral injury is?
I mean, to me, and again, I don't know what the official definition is, but it rings true, like it sounds true. That's kind of how I am with language. Sometimes I like interpret it differently and I just go with whatever it is that I think it means. To me, it's being in the midst of devastation and not having the power to change it. And then the impact of that day after day after day.
Yeah. Wow. So, okay, let's do well, actually, before we do that, let's just show everyone who is watching where you are, where you find your home at OnlySky. So onlysky.media. At the bottom of every OnlySky page is the About Us right at the bottom. And that's where you find the huge number of writers. We are collectively a large number of writers now. But here's Eve's work. And I because in preparation for this, I've read a number of your pieces, and I love the storytelling that you bring to writing about what is essentially non-fiction, but with that kind of language of fiction and that narrative style. So, and we'll talk about that in terms of narrative medicine, like integrating science and the humanities. But I just love some of your writing here. Have you enjoyed being a part of this new community?
Yeah, no, I love it. I am a little intimidated. I feel much less intellectual than everybody else on the site. Sometimes I try to read my colleagues' pieces and I'm like, this is way beyond like philosophically anywhere I've ever been. I love academics, and we can talk about it. I'm about to actually start my master's in narrative medicine, believe it or not, at 55 years old. But I love being in academics, but I think my brain is full from so much I had to learn that I don't hold on to it in the same way I think that some people do, like that sort of argument and all the references and all of that. I have a very qualitative mind, and it's why I've never sort of fit in a traditional medical mold, even though I tried to.
That really explains an awful lot as well in terms of where you are at now, or where you have sort of been through recently in terms of the whole narrative medicine thing, which again we'll come on to. But you're right, like there are but the beauty of OnlySky is that there's something for everyone. There are fiction writers there are poets. I mean, you write poetry as well. There's all sorts going on, and that's lovely. And I think you and I wrote, when the site first opened, we were asked to write what's the meaning of life, and we had 500 words to sum up what we thought the meaning of life was. And I think you wrote a poem, didn't you? So
that just came out. I didn't edit it. I just sort of said it's photographs, like images. I mean, that's how I write anyway. I like say, okay, I'm going to write a story about a patient, and then I have this vision of like the guy on the fire one that I wrote about, this guy who I saw maybe once or twice on a screen, who was disappearing and aggrieved, and just everything about those interactions just stuck with me in this series of images. And I think when we did that, why are we here type response, it was just images, and how can I create? And sometimes I can do it and sometimes I can't, but that was pretty evocative, that theme.
So okay, so that's where we're going to sort of end up, or so to speak. But let's rewind back to your early years. I say this on many of my videos and interviews. Like the default opinion of someone like me, a British guy that lives in apathetic UK that doesn't really care for religion at all. So no religion just doesn't feature in everyday life. Basically, very little. But in America, it seems like the default is that you're religious and then you come out of that in some way. Now, of course, that's a mass generalization. It's certainly not wholly true. But for you, is this what was your formative years in terms of experience of religion?
It's super interesting. It is to me anyway. I'm Jewish. My parents raised us, and we had to go to Hebrew school. And then once we had a bat mitzvah, women have bat, boys have bar. I have two brothers and a sister. Once we had that ceremony, we could decide whether to continue. But the funniest part of it was my parents didn't believe in any of it. Like it was really obvious that it was like going through the motions, and they set us up to be cynical and to not take it seriously. And yet they required that we do a certain amount of religious education. So
what was the reasoning for that? Is it just to be part of the cultural? Is it just sort of part of the cultural identity?
So I thought that it came from mostly my mom's parents, who they always lived close by, and we went to their house for like Hanukkah, Passover, things like that, which were more sort of cultural than Jewish. But I found out recently that my oldest brother, who was always kind of trying to be in charge, told my parents that he wanted a bar mitzvah. And so my parents were like, okay, fine, then you'll all do them. Right?
Yeah. You can't just cherry pick. It's like, if one of you is going to have them, you're all going to have them.
Yeah. So it was interesting. And I just always got in trouble in Hebrew school. And I always got in trouble at Hebrew camp, which, by the way, I loved. I mean, Hebrew camp was like, I have essays I've started about it. There will be an essay about Jewish camp. I mean, it was amazing, like having your first kiss under a gigantic menorah, or like it was just like the smell of the redwood and the hot chocolate coming from the cafeteria.
Right away, what you're saying sounds very different to Jesus camp, and I've seen documentaries on Jesus camp, but and the iterations thereof. But like having your first kiss under that just sounds like that's not the case. So Jewish camp sounds a very different place, but I don't know. I could be wrong.
It was different, but I still got in trouble because every time we had to do something religious, I would desecrate it. Like I would scribble I would write on the wall. I wouldn't take anything seriously that was religious, and yet I was sort of forced to go through emotions. And of course I stopped doing anything Jewish once I had my bat mitzvah.
So I'm interested, because I'm always interested in what drives who we are and what we do and what we become. So for you at that age, were you iconoclastic? Were you like, as in like just a naturally someone who would rebel against what people would perceive to be the normative kind of ideas of how things should be? Were you just naturally rebellious?
I was rebellious. I mean, I would say my whole life I've like gotten away with being rebellious while also looking like I'm doing what I'm supposed to be doing.
That's such a sweet spot of like combination there. You're like, I'm cool and rebellious, but actually little did you know I'm doing everything I'm supposed to be doing. Like, you guys think I'm rebellious, but really I'm
getting away with it. And it wasn't always healthy stuff. I'm not going to explain all of it, but I was not always doing good things for myself, but I was still getting good grades. So my parents weren't worried about me.
I'm going to mention another James song. God, you've got me reminiscing now. There's a great James song called Getting Away With It All Messed Up. And the way that you say, like, yeah, I was getting away with it all messed up. Anyway, so you were involved in a nominally Jewish or culturally Jewish background or family who even though you went to Jewish school and you had your bar mitzvah, you weren't Orthodox Jewish or practicing Jewish.
Not really.
And then was that it? Were you secular all the way?
Yes.
Did you ever come across, I take it you went to college, to medical school. So did you ever have any interactions with particularly religious people? Did you stay away from them? What were your ideas of religious youth?
Yeah, I mean, I would say I went to Columbia, so it was a very large Jewish population at that college in New York City. It's sort of a traditional intellectual hub in New York, which often includes a lot of Jewish people. I dated a lot of Jewish people, but ultimately never married a Jewish person. I found that some of the people I connected with the most, like in medical school, were Jewish. I feel like sometimes I do find my soulmates in people who are Jewish, but not always. And my husband's not Jewish, you know. Um, uh, yeah, and then in medicine, I worked at Cedars-Sinai for over 20 years, which is a Jewish hospital. Okay,
Right.
that doesn't mean that everybody who comes there, works there, anything is Jewish, but there is an overlay. And there is a Jewish star at the top of the hospital. And I did have to deal with orthodoxy as a doctor. And I struggle with any kind of orthodoxy. And it was incredibly challenging, but also really rewarding when I was able to make a connection. It did change some of my bias, I think, against.
That sounds interesting. So let's unpick that. That sounds worthy of a little chat. So there were Orthodox Jews who had particularly challenging viewpoints or rituals or desires to do things in a certain way. Is that fair? Is that what you're saying?
Yeah, especially around end of life. Like,
right. Okay. So this is a good segue. So what do you mean? Explain that.
So there were a couple of circumstances where it was clear when I was doing palliative care in particular. I'm sure I came across it at other times, but those stand out, where like a family member was clearly dying and the family was very, I would say, confused about what they were allowed to do or not do because of their religious laws or beliefs. And we were lucky. Obviously, we had a rabbi who's one of our chaplains who would come in, and he was Orthodox, so he definitely had an understanding, but we were able to have the kind of conversation like, yes, you're not in Jewish law able to withdraw care that you've started, but you can not start it, right? Which was a huge, I don't want to say win, but it was something that gave us this sort of little portal of
loophole.
Yeah. So we were able to say, you know what, this is your opportunity to not put somebody on life support. Like if it's just going to prolong suffering, that's okay per Jewish law.
Wow. Okay. That's interesting, because I do sometimes wonder about this kind of idea about keeping someone alive for the. I mean, I had my granny was in this situation where they've lost all mental faculties. They don't know who anyone is. And I know someone else that's like this at the moment, where you're like, we're keeping this person alive for the sake of keeping them alive because there's some kind of duty to do that, some kind of Hippocratic oath, understanding that we should keep someone alive, where there's literally no hope of them ever regaining any of the faculties they've lost. They have no connection with anyone, and they are a burden. It sounds a very horrible word, but do you know what I mean? They're like people are worse off for them being alive, as in they're an emotional challenge for everyone involved. And so you think, I'm trying to say these things diplomatically so I don't sound like a complete bastard, but so that's interesting that this loophole then allowed for that not to be the case.
Right. And for some people, it was still really difficult. But I had another situation where the patient herself, who had very severe lung disease, privately told me, I don't ever want to be resuscitated, but my family won't let me declare that. So can you help me with this? So we brought the rabbi over and we got the family in the room and were able to complete the advance directive, the form that says that she wanted to not be resuscitated, with the support of the rabbi. And then the family still is like, and there are situations that if somebody's not conscious, the family tries to go against what the patient even expresses. Yeah. And that's our role, is to say this, as long as they've written. I mean, the hard part are those situations you're talking about. Nobody talked about it, and then something happened and they can't speak for themselves. And so you want to designate that person who best understands who you are, to say they would never want this. And even if it's not written down, at least to have somebody who knows you that well, who can step in and say they would not want this, stop, right?
Yeah.
It's essential.
Because it's such a common thing that you hear. So many people, in fact, almost everyone I speak to about, obviously I rarely talk about terminal illness and getting, to the very end of your life, but pretty much everyone says, oh, if I ever get to that stage, just turn off the machines. It's almost like a trope. And yet when that actually happens, like, obviously you can't just, no one, the hospitals is a much more difficult situation than that, and then the families get involved. So yeah, it must be a right minefield.
Well, the default is do everything unless we have a document that says, this is what's important to me, and this is what I love and what I miss, honestly, in my conversations with patients, is like, what faculties, if you did not have them, would mean that life's not worth living, right? Like on my advance directive, it says if I'm neurologically not intact, if I can't recognize people, like you're saying about the person I don't want to live. I have that, and I tell my patients that I've filled that out, and I have that in my glove compartment.
Yeah. Yes. So you were talking a little bit about palliative care, but before that, you say you're a doctor, hospitalist. What got you into being a doctor? What were your influences? Was it a kind of just something you were good at the subjects that led on to being a doctor? Was it something you thought I always wanted to be a doctor? Was it the moral side of being a doctor, or
No. I was going to be a dancer and a singer. I was going to be on Broadway, or I was going to be a writer. But in my family, those things are hard to there's always someone better than you. I was like, I'm a good singer, but I'm never going to be a great singer. I loved singing. Like if I could do anything, I would be a singer, right? I'm an okay singer. But I also found I was always from middle school on, very intense. Like I literally had friends like break up with me because I was too intense. Like that's the kind of intense I was. Like I was in a crisis. If you wanted someone to talk to, I was like first in line and like really good at talking to people. But I was like, no one wants their like 13-year-old best friend to be like, always analyzing everything. So I thought about being a psychiatrist when I was in like 10th grade. So I was like 14 or whatever. And then I sort of got more into the dance and all that stuff. And then I went to college thinking I was going to be pre-med. And a lot of things that have happened to me have been like aha moments, like literally like one conversation changes the course of everything. And that's sort of, I went to college, I was pre-med. I was like, I'm at this great liberal arts college. I don't want to be worrying about getting A's and competing with all these geniusy science people, which I was not. That was not easy. I had a conversation with a friend of mine, came to visit me and stayed with me for months. It was a whole thing. I don't know. And her stepdad showed up and we went out to breakfast and he said, study English. You're at Columbia. So I did. Like, I just like changed course.
Yeah. All right. I'll do that. Thanks.
So I studied English and I actually got my master's, which is really laughable because I don't remember literature. Like I'm trying to relearn it through narrative medicine, but like I did term paper on Virginia Woolf and I did something else on like 16th century plays and all of that, but I don't have it in my brain anymore. But that was how I made that turn. And then I had a really rough year, my master's year, which is a whole other story. And I was like, do I want to go to med school or do I want to go to psychology grad school? And I said, I'm going to go back to LA. I was still in New York. And I'm going to take a biology class. And if I like it, I'll go to med school. And if I don't like it, I'll get my psychology degree. And I loved it. So I went back and did all my pre-med requirements and went to med school.
Nice one. And then you became a doctor. And then you moved into palliative care. There was, I want to read out a little bit before we get on to, I suppose we're doing this maybe a little bit the wrong way around than I was going to do it originally, which is talk about narrative medicine before palliative care. But we're at palliative care. I think we talked a little bit about that. So you were a hospitalist. You went into palliative care, And I think there was a just great quote from one of your pieces that said, "Embedded in the palliative care mindset is the knowledge that you cannot force an outcome when dealing with human emotion. There is no timeline on finding acceptance before death. The palliative credo insists on you meet patients where they are, not where you want them to be." And I thought that was really made me think there. So before we just talk a little bit about that, what just broadly, what is palliative care, and what are the intentions of palliative care?
Yeah. So palliative care is a kind of specialty that really focuses on quality of life in the setting of serious illness. So, everybody knows about hospice care, but that's really only about the last 6 months of life. Palliative care moves that kind of care upstream, meaning at the time of diagnosis of a serious illness. So somebody can have 10 years to live and still be appropriate for palliative
Oh,
care.
really?
Mhm.
Right. Because
Yep.
I would have thought that was the other way around. Right. Okay.
So hospice is palliative care, but palliative care is not necessarily hospice, right? And I actually read research that said if you even mention hospice when you're talking about palliative care, people still think they're the same thing. So I probably just made that error, but just suffice it to say, I've seen patients who have cancers that might even be curable, but that have a high risk associated with their treatment. So I've walked through that treatment with them. Some of them got worse and did end up dying, and some of them lived for years, right? Or some people who have heart failure, they have sort of this stepwise decline. Like they'll go down a little and then stabilize and then go down a little. And this can be 10, 15 years, right? But in the process, they might have anxiety, have shortness of breath, have depression, still need to talk about what they want to do if things do get worse suddenly for some reason. So all of those are things that palliative care focuses on.
So you were a hospitalist, and then at some point you said, and I think in one of your pieces you were talking about how you were trying to spend some time giving quality time to someone who was in this situation, but you felt that as you did that, you then went back on the ward or whatever, and you had to rush through the rest of your shift, not giving people the time they demanded or needed because you'd given almost too much time to the person you were with. And so you thought something's got to give here. I can't work like this. I hope I'm not misrepresenting you. So you thought, right, I'm going to move to palliative care. Talk us a little bit about what you saw, what attracted you towards palliative care.
Yeah. I'm going to back up just a little bit.
Yeah, please do.
And I know I'm going to mess you up. I've been accused of being associative. So anyway, my father is also a doctor. And so I didn't mean to leave out that he wasn't a huge reason why I went into medicine. He loved what he did. Even if he was on call nights and weekends, and yes, he wasn't around that much growing up, but he was so fulfilled and happy with work. And I used to go on rounds with him when I was in high school, considering it. So I did actually study what he studied first, which is nephrology. So I'm a nephrologist, which is the study of kidneys. And I did that initially and went into practice with my dad, which I did for 6 years before I became a hospitalist. But the whole time I did it, I felt like it was, and I also had 3 kids during that 6-year period. So it didn't really lend itself to the best focus, but I felt like it wasn't where I belonged. Like I took that path because I liked nephrology and obviously the opportunity to work with my dad, which was wonderful. And he was a bit of an old school doctor, right? Like he did go to people's homes. He would every Christmas have like so many gifts coming home because he really like went out to dinner with his patients and they would, he would go on vacation. I mean, it's just like he was kind of old school. So my model of like humane medicine did in some ways come from my dad.
Yeah, I bet.
He retired when the electronic record came out in our hospital. He just said, I'm out. And I'm not sure he would agree with my assessment of that, but I remember him saying, can you just show me how to write a little note? I just knew, like, and he's the smartest guy, like way more academic and mathematical and everything than I am.
Was it kind of like, it's taken me decades to perfect the doctor's handwriting here. Like,
Yeah.
it is notoriously bad, and now you're saying I can't utilize this? I'm not doing it.
And he had horrible writing, but so yeah, backing up. So when I came back to medicine after taking a little bit of time with my kids, I said, what do I want to do? And I actually it was one of those moments again. I went to like a career coach, like random, and she had a whiteboard and she said, what do you miss? And what do you envision? And I said, I wish I could just be in the hospital. And at the time I didn't know there was such thing as a hospitalist because it didn't really exist when I was in training. So I called the Cedars where I'd done my training, the residency director. I said, I think I want to work in the hospital. How do I do this? And he gave me a business card, and I think I still have it, with this guy's name on it, and said, go talk to him. And then he was the head of the hospitalist program at Cedars. So it was just those moments where thing happened. I feel very lucky that I have had a lot of those moments.
Sliding doors moments. Yeah, absolutely. So, and then the end result being, the palliative care. So you ending up, so what was it? What was the attraction to that palliative care then? What made you think that actually that's where I belong at that time?
So again, I'm going to take you on a little bit of a journey, but I was doing hospitalist, which I loved. I mean, I absolutely loved it. It was so exciting. It had that like epinephrine surge, like excitement all night long, going to the ER, admitting patients, following them through. You also got a couple weeks off per month because you worked like 12 to 14 days in a row, and then you got a couple of weeks off. As my piece says, I started to feel like, I'd look at my list and feel that dread. I have 17 patients to see today. And I'd be like, okay, this one can only take 10 minutes because this one and this one and this one are going to take longer. And then one of the 10-minute ones, I'd walk in and they'd be having a meltdown, right? And they wanted to talk. And I'd be like, I don't have time to talk to the person who had the knee replacement. I need to save my attention for the one who has cancer, So it just started to not work. And then I met my friend Susan, who I talk about in the piece. And I was like, I want to do what she's doing. Like she is only seeing however many patients in a day, and she really knows them and is really connected to them. So I started to make a move towards palliative care, and I studied for my boards because it was the last time you could do boards without actually doing fellowship training. And then I had a brain hemorrhage and I was in the hospital for 10 days.
Wow.
Yeah. So that changed everything. And it actually just kept me along that path.
Wow. So yeah, that's going to affect anyone, I suppose. But was it? Are you always someone that has enjoyed the personal touch, but the interpersonal communication and like making connections with people? Is that what palliative care is broadly about?
I think that I got caught up when I was a hospitalist in the energy, and I wasn't something got missed, and I was focusing on the medicine, like how to stop a heart rhythm or how to treat flesh-eating wounds, and I got more into the science in a way than I ever had. And nephrology was like that too. And with the electronic record and with the number of patients and all the demands, I sort of put the human connection lower and lower. And when those moments happened, like with Marcia, who, she's a real person, information changed, all of that. I was like, wow, that felt really bad. Like I did something really wrong. And it sort of made me step back and say, that's always the most important thing, and I was missing it. So it literally was another turning point. I know when I first started writing this essay in a writing class, and then I went through it with a coach at some point, and it was like hard for people to believe that one moment can change you. But I've had so many of those moments, right? That's how I've changed course throughout my life. And that was it.
Yeah, and that speaks. It's a really interesting tension that you're talking about with regard to how there's a large aspect to hospitals and healthcare, which is about the science, which is about what's going to cure this? What has the highest probability of curing this at the most efficient, with the most efficiency, and talk about cost benefits and effectiveness and blah, blah, blah. And you're like, okay, and how does it work on this part of the body and blah, blah, blah. And then you're saying as well that hang on, with all this, we've still got a whole human being that we need to kind of nurture and make connections with, because actually there's a validity to that as well.
Well, and the other part is you can't even give good care without doing that. And that's what I started to realize. And it gets to this sort of health equity thing, which is very much integrated into narrative medicine. And we can talk about that too. But it's about like, you can't, we have language in medicine that is very stigmatizing and very judgmental. Like if a patient is like this patient, Marcia, like, why isn't she going with the plan? Why isn't she accepting hospice when clearly there's nothing else we have for her? Or another patient in a clinic, why aren't they taking their blood pressure medicine? They're non-compliant. Like that term, I'm trying to erase it from my organization. Like non-compliant does not describe anything. What it means is that you need to find out why. Like that's just a signal of, hey, I notice you're not, like, just name the behavior. I notice you're not taking your medicine. Can you tell me a little bit about that?
That's the whole nature of everything, right? So when we talk about politics, you talk about Trump, and I don't know where you stand on politics, but from my point of view, you have this whole like Trumpianism that happened over 4 years, and you're like, oh, look at this terrible situation, as if like Trump caused this. No, Trump is a reflection of this. So if someone's feeling the need to vote for this person, who I would think, well, that's morally really problematic, there's no point. I mean, the problem is, I, as a writer, often jump on people that do that, and a very kind of value judgment sort of statements and attacks that I make. But actually, what we need to do is better understand why those people feel the need to vote for someone like that, why that person speaks to them. And once you understand that, then you're better able to treat the core problem. So, what you're saying here is very much the same, which is like, there's no point talking about non-compliance when we should be talking about, why this person is making the decisions they're making.
And yet I struggle so much when it comes to political people who are on that end of the spectrum. And it is so, so hard, because when you're talking about racism and you're talking about homophobia and you're talking about taking women's rights away, like it's just, I don't know. Having that kind of, that's a goal, right? It's a goal for me.
It's funny you said it. I wrote a piece quite early on for OnlySky talking about how it might have even been my free will bit. How was free? So I don't believe in libertarian free will. So philosophically, that's easy to understand, and we can, whatever. But how's that changed the way I do my life? And actually, in many areas, it facilitates me understanding why people do stuff without so much judgment. It's like, right, you're doing that, and that's really probably so. A crime, like, why is this area more prevalent for crime? Why are you guys, as a social demographic segment of society, why do you guys commit more crime than these guys, or whatever, right? And then I get all analytical and I say, right, that. But then when I say go to politics and say you blah blah blah, and I get really judgmental, and it's like I'm being really hypocritical here, because I'm not applying that across the board, and that made me, writing that piece really made me realize my double standards there. So sorry, I just thought
no, I have the same issue. And like, if it comes to like crime or whatever, I'm gonna be like, what in your background, like what experience, what trauma did you have? But I'm thinking white nationalists had a lot of trauma, right? And like and some of the shows that are on where people talk to skinheads or whatever, like I would love to do that. I mean, I really would. I mean, and I think it might change me if I was able. And I feel like there is a part of me that wishes that I had been like a negotiator. Like that would have been a really interesting job. I always think about jobs that I wish I had, and that I wish I had like 5 lives to try different jobs, but whether
did you write a piece called What If?
What's that?
Did you write a piece called What If?
I did, but that's really about letting go of the corporate world. I'm not sure if that came through or not,
Right,
but
okay.
we just stopped all of this because, yeah.
Yeah, maybe you might have one of those, turn the corner moments, and you like 10 years time, we'll see Eve Makoff, hostage negotiator or something.
I would love that. I would love that. I've always wanted to work in prisons and do healthcare in prisons, and it just hasn't happened yet. So there are a lot of things, I think right here in our country, a lot of people want to go abroad, and I'm sure that would be interesting too. But
so
yeah.
Dealing with death, I mean, I've thought quite a bit about this, and I've written on this, and I've done a video, and sorry for my viewers because I do mention this quite a lot, but the idea of terror management theory, I think the whole reason religions exist, literally the core reason they initially exist, everything else is sort of window dressing and gets added on over thousands of years, but really, why did religions exist or believe in God? And it's because of the afterlife. It's the promise of eternal life. And because that allows you a mechanism to deal with it's called mortality salience, like the fear of death and the terror of death. Now, for some people who are staunchly atheistic and happily secular and really certain in that, death isn't a problem because you kind of got over that and whatever. And for people who are staunchly religious, your religion that's what I'm talking about. That's the mechanism that allows you to deal with death. But there's an awful lot of people in between, maybe agnostic, not really certain. Life is a bit more, I don't know, whatever, who would struggle with death. How have you experienced treating people with death in terms of treating people who are facing death in terms of how they cope?
Yeah, I mean, I have
a lot to unpack there.
A lot of thoughts. And the other thing about religion, and again, I'm not a scholar, and it's something I want to look into more, has to do with at times of trauma, whether it was in the Holocaust or slavery or whatever. I think if people didn't believe there was something better, then how do you cope with what you're in? So I think a lot of it, and that's why I don't completely discount religion, because I think that there are some people who it has been so crucial to their survival that it would be very hard to become. And I don't know, I still don't understand it. Like I there are times I wished I could be more religious because I feel like it provides certain things that, in terms of, I see, Jewish people walking to synagogue in their families every Friday night or Saturday. And I'm like, what a nice routine. Like, I mean, it's just, there's something like they feel, but when I go to temple, I feel like I don't belong, but this sense of belonging and same thing, I think in some evangelical churches, especially Black churches, where there's just this beautiful music and togetherness, that I can understand that it's hard to get away from that.
Yeah, absolutely right. And I think that I would then start talking about evolutionary psychology and how the reason, that's exactly the function that religion provides, because that's what we need it to provide. And therefore that's how it's developed, or it's developed in consonance with our needs, which is, social coherence, community cohesion, and the need to be able to cope. So there's a thing in psychology called the just world theory, which is the idea that, and we all have it, I think, whether we're secular or not. I wrote a piece on how my partner, who is no longer religious, our boys, when we moved into this new house, we had this big expensive range oven that came with the house, and they were pushing each other on this wheelie chair, and one of them pushed the other into the oven door, and it shattered, and we couldn't find a replacement for the oven door, and it was going to cost us an absolute arm and a leg to replace the whole oven, right? And so my partner was like, oh, this happened for a reason. I bet that oven was going to kick off carbon monoxide poisoning, blah blah blah. And so I wrote a piece on this because I found it fascinating, because for a non-religious person, she was justifying why shit happens, right? And the idea that so naturally this is something inside us that we have a real need to do. Like, it can't just be that the universe is unfair, like that. No one really likes that, and therefore, which I think is what you're saying, which is if you're in the Holocaust and you're sitting there going, "Why? We're the chosen ones. Why is this happening?" right?
Yeah.
It either goes to a complete rejection of God, like that's just, or it's like the only way to justify this is to make this world just is to invent heaven, and
Right. And that superstitious thing, like I wear this necklace that was my grandmother's. She believed in the power of pyramids and in the power of X. Okay. And
eggs
and
or
she built a pyramid in her living room that she would sit under. Okay. My Jewish grandmother.
wow.
I wish I had asked more questions. I love this necklace that was hers, and she didn't die till she was 100. And
Wow. Well, I'll tell you what, pyramids did their job, didn't they?
right, it has a pyramid and an X inside the pyramid. So this is a super powerful necklace to me. Like anytime I want good luck, so I wore it today, I put it on, and I'm aware that I'm being superstitious in a certain way, and yet I'm not religious, right?
Isn't that funny? Yeah, and it's because it's that what if, like what it's almost like the autistic's sort of OCD, walking on the cracks in the pavement, like, and then you're like, well, I rationally know that's obviously bad luck isn't going to come but I just can't stop myself doing it, or it's a what if it is true, or all these sort of things.
But it makes you feel safe, and I think in the setting of end of life,
Yeah.
I've seen. Yeah, I mean, really, really interesting things. I definitely, certainly there's some religious aspects, as I alluded to, that make people feel like, and this makes no sense, right? Like, well, I can't not do certain things because God's the one who gets to decide when I die. And I'm like, yeah, but God didn't create a ventilator, right? Or pads that are going to charge, So sometimes you get into that territory, which is, You're saying God's going to say when, but did God invent technology? I mean, yes, I guess suppose God did invent technology if you believe in God. So sometimes there's that sort of argument, and then sometimes there's the opposite, which is, I don't need to do anymore. I've lived, the life according to, my religion, and I feel at peace because I did what I was supposed to do, and now it's in God's hands, right? So I've also seen that, and then I've seen people who are just not religious and just full on existential distress because they can't make meaning of it. And I think religion might help certain people make meaning. And like we're talking about, sort of make it a more of a controlled exit, a palatable exit. Whereas somebody who say they're not religious, they're not really happy with how their life turned out. Maybe they're alone and there's so much anxiety. And so we do bring in the chaplain. And I say, this is not religious. This is just somebody who's a really good listener and somebody who, is spiritual in whatever way that resonates for you. And, we have the therapist, the chaplain, the palliative team to just sort of try to figure out a way to nudge someone closer to peace, which is really what we're hoping for.
We have quite a big movement in the UK at the moment with humanist chaplains. So and they quite often get news at the moment because there are more and more hospitals that are allowing places for humanist chaplains, which is absolutely fantastic. Really, really think it's a worthy thing, but for exactly those sort of reasons. Like, it isn't necessarily about providing you some theological framework, but it's about psychological comfort in whatever way that like be, that's atheism, like, is a hard sell. When you, like, if you got a choice, like you're on your deathbed and someone comes to you and says, all right, do you know what, you're going to be reunited with the creator and you're going to be in heaven for eternity. You're like, okay, right. I can't conceive of anything that's better than that. Because whatever you say heaven, or whatever I think heaven is the greatest thing in human conception, right? So you're basically saying, I am going to get the greatest thing in human conception now. Whereas the atheist comes along and says, hey, it's not a problem. You're going to become stardust, or it's going to, you can dress it up nicely, but it's like, yeah, you're going to die and that's it,
Yeah. No, it's incredible. Yeah. I feel so honored to have had these kinds of conversations with people. I mean, there is nothing like it. And it's funny because Susan, who I talk about in a lot of my writing, she's my good friend and we talk all the time and she just appears in my writing. And we were talking, we're both in like corporate medicine now. We're both not seeing patients. But the love of our lives were those interactions that we had with patients. And we're both like, do we start a business? Do we just volunteer at a hospice? Do we, like it's still once you're given that sort of honor and opportunity to, I mean, it's just connection. And I have to say, it's hard to say why, but a bioethicist who I worked with at Cedars-Sinai, we were in a meeting. We used to do family meetings in the ICU, which I also miss, where you have the ICU team, the family, the bioethicist, the palliative care team, and you say, hey, look, this is what's happening with your loved one. Let's give you all the information you need and kind of work through it and figure it out. And I said to him, I don't know why I love this work so much. And he said, the bioethicist, because there's no bullshit. Like in that room, when you're talking about death and you're talking about like the most human, the thing that unites all of us, our physicality, our, the fact that we're not here forever, there's absolutely no fluff, right?
Are you talking about in those meetings, there's no fluff? Or
In the
field, do you ever find that you would speak to someone, or there are maybe chaplains or whoever that speaks to people who are going to die and does actually kind of lie to them to comfort them, like a good lie? Is that something that happens? So
in our training in palliative care, it's written, you don't sugarcoat it. You don't promise things. And this is something that, and in that piece and in other things that I've written, a lot of doctors are not comfortable not doing, right? Like, and this is why I think palliative care exists, is because other doctors can't say, like in that piece, like he just couldn't say there are no other options to treat your cancer, but we can shift to a different kind of care, right?
So it's
one more thing.
Just to let people know, viewers know. So what happened in the piece that I pulled up earlier, you had this situation where Marcia, as you called her, was coming back into hospital, very bloated because she needed sort of draining from chemo. Is that correct? And then, but actually things were looking bad and chemo wasn't working. So the doctor was speaking to you and basically said, yeah, it's not looking good. We're going to have to tell her. And then she said, what's the news? And he broadly said, oh, it's not looking good. Chemo's not working, but there is this pill you could take.
Yeah.
Do you want to explain that sort of like what's going on psychologically?
I've been in that room so many times where before we enter the room, the specialist says, this is going to be hard. We're going to have to tell her, and then goes in the room and can't tell her. Right. And it's because we have so many new medicines too that, sometimes they're being used off label or they're in clinical trials, or we've signed them up for a phase 1 trial, which is another piece I have to write. Phase 1 trials are to look at side effects to make sure things are safe. In a small percentage, you might see benefit. Sometimes you do, but it's like less than 10% are going to have any benefit from a phase 1 trial. So he, you come in and she says, he says, look, the scan shows that the cancer's growing. The fluid is because the liver's failing. And when your liver fails, you fill it with fluid. And then you get a paracentesis where they drain that fluid out, and then they have to have that every week. Right. And sometimes you get it put in there. So you have a drain at home and you drain it, which is really what I wanted to do with her, was have her put a drain in, go home, have hospice take care of the drain, all of that. But no, and he said, but there is this oral medicine, and then the whole conversation, and you as a palliative provider can't go against what their specialist is saying, because then they're just going to triangulate and say, well, I'm going to listen to the one I want to listen to, who's giving me the news that I want.
Yeah. So what you as a patient are like, I'm going to cling on and grasp hold of how, no matter how diminishingly small the probability is of something that you've given me, and then I'm going to go with that because I could be the one.
Exactly. Yeah. And I get it, you know. I mean, some people are say if there's 1% chance, I'm going to go through that. And then maybe they feel like they're contributing to science. So that's another piece.
Yeah. Well, yeah, which is interesting. So when to return back to your quote here, embedded in the palliative care mindset is the knowledge that you cannot force an outcome when dealing with human emotion. There is no timeline on finding acceptance before death. The palliative credo insists you meet patients where they are, not where you want them to be. So what I read from that is the idea that you know, you ideally would like someone to just really easily accept death. Right, on their deathbed, you come in and say blah 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 blah, and they go, "That's amazing, Dr. Makoff. Brilliant. Thank you for that. I'm ready to die." But of course, that's never going to happen, and they might meet you with resistance, but you can't force them to where you want them to be. Talk to that a little bit.
Yeah, and I have to say, it got to a point where those were the most meaningful moments. You know, where I'm like, I start with, what is your understanding of where you are? Always. That is
nice. Yeah.
Question, right? Where do you know, what is your understanding of your disease, where it is? And then do you want me to tell you what I know about it? Are you ready to hear that? And then are you ready to have a conversation about where we go from here? There's a lot of asking for permission, right? And then if there's that resistance or that sort of shutdown, being able to say, I'm sensing that this is really hard for you, or you don't want to go here, or you're not ready to talk about this. And there's another piece that I keep trying to write that is, I'm trying to show that conversation. I think it's interesting to people because when I've in writing groups shared some of that, they like the in the room type of thing where you see that. But it's hard to make it an interesting story, like with drama, you know, of just a conversation. But like when I teach people, I always go back to this patient I had in a cancer center who was sent to me against her will. Like she was dying and she had a lot of pain, and a lot of the oncologists didn't like to prescribe things like methadone that I was comfortable prescribing. So they sent her to me for pain management, but also to talk about end of life. And she was in my office like this. Yeah. Right. And I come in and she's just sitting there and I'm like, hi, I'm Dr. Makoff and I'm here. And she wouldn't talk to me. And I just said, you don't want to be here. She said, no, I don't. I'm like, you can go, right? Feel free. You don't have to be here. If you don't think I can help you, that's fine. Okay. So she gets up to go and then she goes, wait, but can you help with my pain? I'm like, sure, I can help with your pain. Okay. And then we started then I just didn't talk about anything else until I got to know her better, right? We just focused on her pain. But when people see palliative care, they look it up and they see hospice. And if they're not ready, they're like, I'm not ready, right? So there are a lot of those moments that were so gratifying because I knew that I had something that could help her, but I also couldn't force her in that moment to accept the whole thing. So I just meet her where she was. She wanted pain management. That was her number one need at that moment.
Maybe I'm having a philosophical moment here. Maybe we're all in palliative care, from the moment we're born. And, you know, life is a series of ways of coping with our eventual demise and the pain of existence. And there you go, a bit of an existentialism there or something. But yeah, and how we best cope with that. And life is just, a series of coping mechanisms. Anyway.
Yeah, but just learning the communication skills that I learned. I went to a bunch of courses at Harvard and I went to MD Anderson and I met with, and just it changed. It literally it's a skill you can learn. Right? Oh, someone making a comment.
Yeah, there's been lots of comments down the side. Sorry, there were people talking about what we're talking about, but this comment, I just thought, steady, JP, I ain't ready. Talking about he's not ready to die. Yeah, I know, but just have a little inkling it's there somewhere. Sorry, I interrupted you. Carry on.
Yeah, no. I just I think it's amazing to me to learn. I think I always thought people were either good communicators or they weren't. And I'm like 100% sure now that you can teach people to be good communicators and good listeners.
Oh, brilliant. Well, we're going to come on to that in a second. I just the last bit on palliative care I wanted to talk about was this. You also write that it is team based, and so this is basically a definition of palliative care to some degree. It is team based and always includes providers who are experts in mental health and spiritual care. And I find spiritual care is interesting. How would you define spirituality and spiritual care?
I think, to me, the word that comes up is transcendence. Like somebody who's sort of, it's an experience of transcendence is a spiritual experience, which is why I can consider myself spiritual, even though I don't consider myself religious. I know some religious people like don't even like to say that they're spiritual, right? I've kind of heard that too. But to me, like when I think about Jewish camp, it was like transcendent, but it had nothing to do with God, right? So for me, it's a way, and it also has to do with managing existential distress, which I think most people have near the end of life, except for super religious, honestly, at least in my experience. So I think, therapists help with sort of depression, anxiety, but then there's this extra piece that isn't like, it's not like people will say to me, like when I ask my cancer patients, are you depressed? Are you feeling depressed? Are you sad? And then whatever. They say, well, isn't everyone who has cancer? I say, no. I have a lot of patients who are not depressed. And those are the people who don't have that existential element too, So they kind of work hand in hand, the mental health and the spiritual distress piece. So palliative care is said to be transdisciplinary, which means that every part of the team overlaps with everyone else, all of our skill sets. Like I do some mental health care, I do some spiritual care. The chaplain might assess for pain. The social worker might, talk about nausea. So I think we all do all of it. And that's why and it's too much for one person to do it. Yeah. So you need the team.
So when you talk, I'm interested about this kind of idea of spirituality. So when you talk about transcendence, what is transcending what? What do you think? So what do you mean by, because I say this, I wrote one of my first pieces for OnlySky was what is transcendence? Because someone brought it up in argument to, the soul is transcendent and this is transcendent. And I was like, these different ideas going on with the different uses of transcendent. What is transcendence? Transcendence in general, transcendence in this particular, what transcends what? So to you, what does transcendence mean?
Yeah, it's making me think, and I might be going off track. It's making me think of a new book called Bittersweet by Susan Cain, who wrote Quiet. And it's sort of like being moved, it's about being moved, and it's almost melancholic, right? This sense of like connecting to something outside yourself that is sort of universal. And I think it's when it comes to the end of life, like that can be a positive sense of connection, or it can be a devastating sort of connection. And I don't know if it's making any sense. I'm, kind of in my own head here, but I feel like the reason that chaplains are so different and important is that they're not looking at the DSM-5, looking for a diagnosis. They're not looking for anything that's a disorder. They're looking for something that is normal, but how to help manage how it shows up for different people who are dealing with this vast, sometimes scary unknown that is the end of life. And in there is like transcendence.
I don't know. Have you watched Midnight Mass on Netflix?
Mm-mm.
So it's a Mike Flanagan written and produced or directed show, 7-part miniseries, limited series. And I loved it. I've just finished watching it today. And it's got ponderous moments in it. And by ponderous, I mean it's pondering on things. Like the whole thing is about death, really. But it's about religion. There's loads of great theology and counter apologetics and all sorts going on in there. It's just, so it's essentially a horror, but the horror is a vehicle. It's not really crazy horror, but the horror is a vehicle to deliver all of his ideas on these things about miracles, about religion, about the Bible and all this kind of stuff. And the two key moments are where there's this guy who's an atheist and a woman who is basically sort of atheist as well-ish, but they're talking about death. What do you think death is? And she's just lost a baby, and she says, well, I think the baby goes to heaven and then like grows up straight away, becomes a perfect version of who she would have become, and then is united with God or whatever. And then at the end of the series, she ends up dying and then replaying this conversation and then giving her monologue. So the final monologue in the whole series is what her idea of death is. And it is, I've got goosebumps. It is a stunning piece of writing that I want to, it's just brilliant. I'm going to write a piece on this. I'm going to write a piece on OnlySky on Midnight Mass, because that last, what her definition of death is and what happens at death and the cosmos, and is just remarkable. Anyway, that's me going off on one only because I watched it today, that final episode today. But yeah, Midnight Mass, go and watch it, see what you think, see if you agree or disagree.
I mean, if you really sit down and think what's going to happen when I die, and I think there are moments, like when you work in a cancer center, one of the hazards is you always think you're about to get a deadly cancer. I mean, it's like you live in that place, and in a way it gives you an opportunity to deal with the feelings around it, you know. And I honestly feel like I'm not scared of dying anymore. I mean, and I don't know if it's because of the work I've done or whatever. I've done everything. I have no bucket list or anything like that, but
I wonder if that's a key, actually, which is I know it's really sort of tropey, but kind of like, I've had children now, so tick. I've gone backpacking around the world a couple of times, tick, and I've experienced this and I've experienced that, and like, right. I mean, there are some things, but there'll be luxuries of checklist stuff that I could still do. Yeah, I've got MS now, so I'm not going to do 95% of the stuff I would love to still do. That ain't going to happen. But if I was run over by a bus tomorrow, do you know what? I've had a good innings and I've achieved loads of stuff. And do you know what? I'm happy with. So I'm like, that's different to like getting cancer and being told you got 2 weeks to live. I might feel different, but like now, in my position now, I can say I'm happy to die. Do you know what I mean?
Yeah, and that's a really key point about cancer. Is it's incredibly hard, that prognosis conversation. I mean, I've had dozens of patients say, do you know what it feels like to be given an expiration date? Like, it's one thing to like die like that, or, you know that somewhere, but to say, and we usually give, days to weeks, weeks to months, months to years type thing, because you're always wrong, or you can be. But like in those days to weeks or weeks to months, like people get paralyzed, right?
Yeah.
Some people.
I wrote again, I keep mentioning OnlySky pieces. I wrote a feature article for OnlySky on gene editing, and I did like proper reporting stuff. I interviewed people. I interviewed one of my friends who she's got 2 children, both with health issues. First child at 10 months, I think, had to have a heart transplant, right? And it was all like the whole thing. The story is quite incredible, but the heart transplant, I didn't realize this, but if you're given a heart transplant, you've got 15 years to live. Like, the transplant will only last like 15 years.
Unless you can get
right? What? Sorry?
Unless you can get another one.
Well, yeah. But the idea that you've like given an expiration date of 15 years to your child.
Yeah.
Like you said, right, you're now going to live. That's brilliant. But 15 years and wow, that must be so hard to deal with.
And even one more, which is getting even farther away, are people who are in remission, from cancer, who very commonly say, I'm supposed to be happy now, and I don't know how to deal with this. Like the fear, the anxiety, the PTSD, the medical trauma from everything that I went through, the pain, the uncertainty, that moment where I got the news that I had cancer. Like, people start to sometimes deal with that when they're in remission.
So I think that's the key. So I want to just show you this article, which you talked about uncertainty, right? And I think that's the key. So when we talk about can you see that? Yeah. So yeah. This is from 2010, 12 years ago, from a local university to me, University of Southampton. Strong beliefs and coping in old age. old age, a case-based comparison of atheism and religious faith. And what this, I'll read out the abstract. Although a variety of research projects have been conducted on the benefits of religious coping in older adults, no direct comparison between atheism and religious faith has been published. Blah, 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 blah. So they talk to different people, strong atheists and strong religious people. And the analyses showed that all the study participants, regardless of the beliefs, were coping well and suggested that a strong atheistic belief system can fulfill the same role as a strong a religious belief system in providing support, explanation, consolation, and inspiration. It is postulated that the strength of people's belief and how those beliefs are used might have some influence on the efficacy of coping than the specific nature of the beliefs, right? So this also plays into loads of psychological evidence to show that people have greater well-being the stronger their beliefs are. It's not what you believe, like whether you believe in God or whether you believe in atheism, but it's how strongly you believe it, because you're like, yeah, I'm happy now because I believe this. It doesn't matter what you're going to say. And it's that big bell curve of people in the middle that struggle more. So that piece of evidence seems to suggest that if you are really strongly committed to whatever belief system you have, you are better able to cope with death. Is that something that chimes with you?
Yeah, that makes a lot of sense. And I think places like OnlySky that create community are probably helpful in that respect, right? Because I think a lot of religion is about that community and that support system. And I think if there are, whether it's political or a writing platform or whatever else, I think if you have a place to share your beliefs and to talk about them and to not feel alone, I think that's the key, right? Yeah. Is just not be lonely. And loneliness is just a huge issue right now with people. And I have a sense that that might be more at the core of not being able to accept what's happening when people are near end of life.
So and just the final on this before we talk about narrative medicine, lonely. So I'm sure you've come across many people lonely, dying with no one to come to their bedside.
Yep.
How does that manifest itself in their psychology?
Yeah, it's just incredible. And it can also be the partner of the person who's dying, like if they only have each other, it makes it much harder on both people.
Yeah.
It's just heartbreaking, because it's something that even in my current job where we deal with elderly people, many of whom are alone, we're trying to figure out ways to address loneliness. And, we bring them into our centers. We have adult daycare, things like that. But, that's a few hours out of your week. We give them caregivers so they have somebody with them. But sometimes you're not close to the person who's helping you as a caregiver. And we try to connect people with online, groups and things like that. But I think, for some people, it seems like they give up too soon if they're lonely. Like, what do I have to live for? My kids aren't talking to me. I heard that a lot. Really? I don't have a relationship with my kids and they are not showing up near end of life. That's pretty heartbreaking. And so some of those people just sort of give up. But others, it's just more of that, again, that distress. And, if they don't have strong beliefs or strong connections, it's that much harder to find peace.
Yeah, Trude Held says theists and atheists have thought things through deeper than the lukewarm whateverists. So the idea that if you've thought about death, like as atheists sometimes do, and as strongly religious people do, obviously, it's in all connected with their religious beliefs, then you're almost pre-prepared. And so, if you're already adamantly feeling that your belief system is fine and you've got that support mechanism in place, then James says, I'm alone in the world and it's a special kind of weight that just never lifts, but I haven't given up hope of changing that. Well, James, for what it's worth, you've got us. Thanks for joining this little community, and we occasionally talk on Facebook as well. So happy days. Loneliness is a silent epidemic. I'm just trying to make that rather depressing thing sound a little bit more upbeat, but I'm failing. So,
but I think it's about making meaning, right? And I think it might be harder to make meaning if you feel very alone. I do think there are opportunities. Like, I know for me, especially during the pandemic, not going out much when I was doing a remote job, I found community when I started taking writing classes. Like I really started writing in 2020, you know, I took like a memoir class, just, I don't even know why I started doing that. Decided I wanted to start doing, and I took it 4 times. And then with the Columbia Narrative Medicine program, which we can talk about, I found a community online. So even though I wasn't seeing people, it did help me feel less lonely. I'm not saying I necessarily felt lonely. I had many people in my home, but I felt like I was making meaning even in the midst of this horrible pandemic that was keeping me apart from a lot of people that I love.
So this is a perfect segue onto where we're going to finish up today, which is talking about narrative medicine. So narrative medicine is something that you are now sort of something of an expert in. Sorry?
In process of becoming.
Yeah, I wasn't quite sure how. Yeah, but this is something I'd never heard of. And there's an interesting, again, sort of tension, or maybe not tension, but like counterintuitive idea of splicing together the humanities and the sciences here.
Yeah.
I'm going to read a quote from one of your brilliant pieces again on OnlySky, and this will build up an idea for the viewers of what narrative medicine is before you can then tell us properly what it is. So you say the field of narrative medicine and the pedagogy of close reading that underpins it was created in the year 2000 by Dr. Rita Caron, also bearing an MD and a PhD in literature, combining medicine, literary criticism, anthropology, oral history, phenomenology, consciousness studies, and aesthetic theory, among others. She has systematized a way to teach healthcare providers how to garner a kind of self-awareness to engage in radical listening, letting patients tell the story of their illness as they see it, going beyond symptoms to include emotions, thoughts, and events. And I thought that list of different disciplines you talk about there, phenomenology, which is sort of experience, consciousness studies, aesthetic theory, like oral history, anthropology, and these are just fascinating areas that you're combining. So, wow, what is literary? What is narrative medicine? Tell us about it.
Yeah. So first of all, I'm very unwilling to call myself an expert in anything until I feel like I'm really, really good at it. So I am just finishing a CPA, a certificate program at Columbia in narrative medicine. And because I want to be a full expert, I'm going on to get my Master's of Science starting in August at USC, which is local. And the Columbia program was all remote. So I'm very excited because I have not done narrative medicine in person. So I'm very excited to do that.
I'm so confident in you. I was just being merely predictive. Like you're an expert to be, but I was just shortcutting the to be bit.
Yeah, no. I am in process. It's a very hard thing to explain, but I will try because it's something that's almost like when you experience it, and here comes that word transcendent again, it is transcendent. Like it is just a remarkable thing that happens in the room. And I've only done it in a virtual room. So I'm very excited to, be in a real room with real people. But it's 2 things. One is a way of being in a patient encounter, and it very much dovetails with palliative care. It's the same skill set, right? It's that concept of radical listening where everybody does this to an extent. Someone's telling you something and you go, oh, I know, that happened to me too, right? It's the ability to not do that, right? It's the...
I do that all the time.
Right? Like, and I talk about this with my husband. He's like, I know, I do that all the time. I'm like, no. It's a natural thing to do, right? To make you're making a connection to people, but really to be in that room and ask questions that open it up instead of shut it down. Like, I feel like traditional medicine we're trying to check boxes and cross T's and dot I's. And we need to get this is, in my brain, the history and physical, the chief complaint, the history of present illness, the review of systems, the past medical history, the past surgical history, the social history. Then we do the physical exam, and then we do our assessment and plan. And that's what we're going to do. Like, you're literally like when you're in medical school and you're learning that, like, I remember that going through my brain, like, I have to get through these elements, right? What Rita Sharon says is that there has to be like this alternative chart, which is like, what do you dream about? What's the most important thing to you in your life? And what keeps you going? And what are you hoping for? And who are your people? And what are those relationships like, right? So, which is very much what we do in palliative care. So narrative medicine, you can say you have a narrative approach to medicine, which is really taking in a patient's story and where they came from. And it's part of health equity, because if you have a patient, and there's another story that is in a memoir in progress that may or may not ever get written, but a patient who came to me, she was referred by the oncologist because she was anxious. And she came in, a Black woman. I loved it. She was carrying the Mueller report when she came into my office. Like, it was back then, and, you know, like the Trump's whole thing. So I kind of knew what I was dealing with. And at the time I was working in an environment that had mostly patients that were very conservative, which I had to deal with. But she said, I'm not anxious. I don't need a psychiatrist. My cancer is growing and no one's believing me, right? Like, I just need a CAT scan. Can you help me get a CAT scan? I'm like, that's not really what my role is, but let's talk about that. You don't feel like you're being heard. And I let her go. And we talked for 2 hours. I used to block 2 hours every time I met with her because she needed to feel heard. And that narrative thing was figuring out, she came in with her own agenda, which was fine. I couldn't have my agenda because that she would have completely walked out the door. If I said, well, let's talk about your anxiety, that's why you're here. She's like, I'm not anxious. No one's listening to me. And she was right. I ended up ordering a CAT scan, and her cancer was progressing, but no one was believing her. And in the course of getting to know her, she was talking to me about the daily racism that happened in her life, going to the bank and them asking her for 2 forms of ID when the guy in front of her just walked up with his debit card, all kinds of things. And it sort of was another of those moments. And that was the first thing that I wrote and got published, was about her, about that relationship that I developed with her. So that was sort of like a narrative approach, was like letting her tell her own story on her time, on her terms, and not steering her towards what I wanted, right? Narrative medicine as a pedagogical field is, and especially on the master's level and learning about it, is intended to teach us who are studying it how to teach these sort of communication skills through narrative medicine to other people. Like, my goal would be, and I have many ways that I would love to apply it. Part of it is maybe teaching medical students, right? Because in trying to incorporate some of this in my current job, it's hard because people are full-formed clinicians, and that's the hardest thing. Like, it is teachable to be a good listener and a good communicator and to really appreciate the whole patient. But once people have been in practice for 5, 10, 15, 20 years, it's much harder to sort of change their approach.
Well, it's time is money as well, isn't it? So if you're saying, like, you know, as someone who's making decisions about how much this ward costs or how much this hospital costs, if you're factoring, like, you know, expensive doctors spending a couple of hours talking to patients to get there, you know, that then becomes quite controversial, I would have thought.
And yet, and yes, I mean, I think part of narrative medicine is that it makes you, it can't help but make you an advocate for change. Because when you look at the data, which is largely qualitative at this point, and we really need more quantitative studies, but there are certain areas, and I'm reading all about qualitative research, which I really knew nothing about, but it's really part of this movement, right? The things that this kind of approach give you is more empathy, right? So we're looking at patient satisfaction scores. That's one of corporate medicine's biggest targets, right? We're looking at turnover, burnout, resilience in practitioners. We're looking at team coherence. Narrative medicine has been shown to help with all of those things. Like, if I make the argument to my, like, we're having high turnover, can I do a monthly narrative medicine workshop because there's data here that shows that it decreases turnover and this is how much money we'll save? I can probably get that workshop approved.
Yeah, of course.
But what you point out is the system is part of, you know, obviously the elephant in the room is medicine has to change. Like, I can help people become better communicators. I can help patients be more satisfied. I can help clinicians feel more fulfilled in their jobs and more resilient, but I can't stop work situations where they're being forced to see 20 patients in half a day. Yeah. Like it's, that's something that has to change. Or when there's the other piece is implicit bias is sort of, part and parcel. And so just to explain how narrative medicine workshops work, is so anything is considered a text, right? I mean, not anything, but like it can be a piece of art, a painting. It can be a poem. It can be a little segment from a musical. It can be part of a short story. It can be a whole short story. It can be a song, right? And so you would ideally be in a room with people and put up on a screen a poem, and you would all read it together. You won't have seen the poem ahead of time. It might have a theme. Say the theme is, or something around accepting ambiguity or uncertainty, because you're thinking that in this group of people are super perfectionistic and sort of going to burn out because they're like overdoing it on everything, and you want them to sort of accept that they can't change everything. So you might pick a poem that sort of addresses something like that. You read it together, and then the person who's leading the session is going to ask for some conversation around it. Like, where is this going? Where do you see this going? Or I've seen, and this, like when I think about like ambiguity, there's paintings, especially where you might talk about perspective, like what's in the forefront, what's in the background, like what are those people over there doing? Or in the poem, what are they doing with shadows and light? What's happening? So it becomes this very sort of, but not based on some literary, the people in the room don't have to be, English scholars or literature scholars. They're invited and told, this is a safe place. Nobody's going to hear what you say. We're not recording it. No one's going to, know anything. There's no wrong answers. All of that sort of prefaces it. And then they sort of get into this, oh, it looks like that person actually is really struggling, and that guy over there, or wait, there's a story within a story. So you get into these really intense conversations together, right? And then you stop, and a prompt is put up, and you have 3 or 5 minutes to do some reflective writing. And, say it's about there are a lot of stuff, stories and poems that we use that are about cancer patients or whatever. And maybe it's about, a poem that I used was called Back to Eden, I think it's called, because I love this poet. And I said something like, write for 5 minutes about what your Eden is, right? And so you like turn your camera off, or you're in a room and you write it. And then if you want, you can share what you're writing. And it's like this sort of alchemy of like, wow, I just learned so much about myself and about other people's perspectives by looking at this piece of art, by reading this poem. Like, that guy didn't see at all that woman looked sick. Like, why didn't he recognize that she looked sick? Or why did that guy not see the forest for the trees? I mean, like literally, like you have these conversations. And then, one of the short stories we read was Sonny's Blues, James Baldwin, I think, story. I mean, they were just like, or Odor of Chrysanthemum, D.H. Lawrence, which is about working class. I mean, I get chills thinking about like how much I learned reading that, and thinking about how this wife had to deal with the death of her husband, and she was so angry because he was coming home after going to the bar all the time, but they were, all dying because they lived near mines. And I mean, like, and then you start looking up the context, right, about England at that time, or about James Baldwin or whatever. And it's just the most profound thing. And I feel like it literally like makes you a deeper person, makes you, in a group of people who may not all be like you, understand their perspective, and brings sort of this rich way of looking at the world with you outside of that workshop.
So, but what would the intention be in doing this?
Yeah, I mean,
because I mean, and it's interesting, you talk about art therapy, and but then that's a form of therapy. So is this therapy, or is it something else going on?
So there is, I can't remember his name, Pennebaker, I want to say, who wrote a lot about therapeutic writing, like reflective writing. And there is therapy. We do give that sort of, ahead of time warning, like this isn't therapy, and we will give you resources if it brings something up for you, because for some people it does. It can feel therapeutic. I think the magic in it is in often, especially for healthcare workers, like realizing that you're creative is a piece of it, and increasing your capacity for reflection. Like that's sometimes what's missing in the medical encounter is creativity and reflection. So it's sort of like it teaches you to sort of slow down, not just in your medical encounters. And again, this has been applied to classes in, so it's not necessarily medical, even though it's called narrative medicine. People have used
that's what I was gonna that's actually, sorry to interrupt, but that's literally what I was going to ask you next, which is what's the medicine part of narrative medicine then?
Well, the medicine part is me taking this to work with, like, I have a plan to work with some medical residents, and I want to tailor it to, because they're at the beginning of their career, to looking at issues around professional identity formation. So I'm going to pick, depending on who the audience is, who they are with me in the room, like what might they be struggling with? Like the residents I'm working with are non-white. And so what does that feel like in the medical profession that is largely white? And, you know, so addressing some issues depending on what your audience is. But these kind of exercises have been done in multiple areas with it at a, you know, inpatient eating disorders clinic to talk about identity, because so much of an eating disorder is difficulty, you know, kind of figuring out what your identity is separate from whatever other cultural or other expectations. Yes, in law school, I know they did something, I think it was in the law school or the business school at Columbia, one of my teachers did something around bias. And so that really depends on what text you choose and how you lead the conversation and what kind of reflective writing you do. There was an essay or an article written about sort of a more social justice focused narrative medicine workshop where they did, you know, qualitative research. So they interviewed the people afterwards to see what they got out of it. And they really shared that it made them really think differently about their own implicit bias. And so it really just is I think if I was going to sort of distill it, I would say it helps you know yourself better. And I think you're a better doctor and a better person if you know yourself better.
I was just going to say, then what's the point of knowing yourself better then? Do you know what I mean? Like, how do you derive this further and further? You write in one of your pieces, in 2020 frame, which stands for the fundamental role of the arts and humanities in medical education. So that sounds like the organization that's kind of overseeing this or heavily involved in this. Laid out the argument and evidence for integrating art and medicine, listing to enhance the patient experience. So these are all like, what's the success criteria of this? Why bother doing this, right? To enhance the patient experience, to improve population health, reduce costs, and promote clinician well-being. So
yep.
Those seem to be the main advantages. So that's a raison d'etre for this.
Exactly. Yeah. I think medicine is about making connections. You can't, like, I couldn't get the information that I needed from my patients if they weren't willing to tell me, right? Like, how many times I know even when I was in the hospital, I didn't reveal certain things that may have contributed to what happened to me because nobody asked me, first of all, and I didn't create that bond with anybody to feel comfortable, especially as my role as an attending physician at that hospital, right? You're not going to get the crucial information that you need from your patients if they don't trust you, right?
That's really interesting. It's so blindingly obvious. But of course, when you are talking to someone about their health problems, it's a very qualitative, subjective thing, which is I'm feeling bad here, or this is a struggle, blah, blah, blah. They might have a list as long as their arm of things, but if they don't like you or there's no connection made, if someone comes along and says, right, what are your problems? And they'll say maybe 2 or 3 of the main ones. Exactly. And then, you know, whilst leaving out all the others because there's no connection going on. And so the idea, I suppose, is that you thought, I mean, this, and as you've already talked about lots of different contexts to this, business schools and law schools or whatever, like if you have a better relationship I mean, it's simply going to be that if you have a better relationship with someone, you'll be able to get more out of them that's useful for everyone involved.
Right. And that's Rita Sharon who created the field. Now, just to back up though, the FRAME study looks at the humanities in medicine, and the humanities in medicine has been around for a long time, right? Like looking at artwork or doing a tour of a museum with medical students, whatever, introducing comedy for, whatever it is, those kinds of things. Narrative medicine is one example of how humanities and medicine have been brought together. Yeah. And Rita Sharon, above all, says this is how to give the best healthcare, is to have this kind of approach, to use that sort of primary skill of close reading. And that's where it kind of pulls together all of these humanities, fields that you can't understand if you're not paying close attention, right? And so that's, I think, the three pillars of narrative medicine are attention, representation, and affiliation. And that sort of runs through everything that we do, like paying close attention, that sort of radical listening. Representation is taking that story and integrating it into that moment, or in my case, writing about it. Not everybody in narrative medicine writes, but a lot of us do. I mean, a lot of us. Right. And then affiliation is and representation within that is also perspective taking, realizing your blind spots and looking at, bias and racism in medicine and inequity and all of that. And many, many people in narrative medicine are social justice activists and use this for that purpose.
I've been doing some radical listening myself and found out my own blind spot is in terms of pronunciation. And of course, the beauty of language is that very often two things can be completely different but have the same. Well, I was like, Rita Charon is clearly the ferryman over the River Styx in Tartarus.
Much, right?
And you've gone Sharon and I've gone Charon, and I'm obviously wrong, but I like to see Dr. Rita Charon as a ferryman over the River Styx. But you've corrected me; it is Sharon. Obviously, I'm wrong. Sorry.
No, and when I kind of realized that, it's so perfect. It's like she was destined, right? There's that spirituality, right? It was meant to be. Yeah. And narrative medicine, narrative medicine care really come together also, the skills of narrative medicine and palliative care. I personally also, for me, it's just pleasureful, this endeavor. Studying this is just incredibly, it's like, it feels both intellectual and emotional at the same time. And I love that combination.
So it's like applied, I mean, anyone can go to, not anyone, but you can go and do an English degree and get la-di-da, and I'm all like, my literary analysis is top notch, and you're like, yeah, what's the point? Like, it's the end in and of itself, which is absolutely valid and whatnot. But this is like applied, literally literary analysis. This is like all that lovely stuff that you enjoy doing, and art critique and literary critique. Yeah, we're going to take that and writing and all this kind of expression of the humanities, and we're going to apply it to people for a useful end. Brilliant.
Yeah. So my job currently is pretty traditional in a lot of ways. So I try to like work in little narrative medicine exercises where I can. And I had that experience of like how it impacts people. I was asked to do some kind of team building thing for a meeting that was in my company. My part of the company is 800 people, and it was a remote meeting. And my boss was like, well, what can we do for team building? And I had just done a narrative medicine workshop within which we did what's called a co-created poem. So like you read a poem, and then sort of in the shadow of that poem, you start off your co-created poem with like a line from that poem, and then everybody says a line or a sentence, and you, at the end, you read it. And because you've done it sort of in the shadow, subconsciously or unconsciously, of this poem, it ends up sometimes looking like the other poem. And the only rule is that you listen really hard to the person in front of you, and you don't make up what you're going to say until it gets to you. And so we did this at all of our clinics. I had this really simple poem about like all that matters is love, basically. And all 800 in my company in groups of 10 made up these poems. And people were so excited that they were creative. Like, and it was a total team bonding moment. And if that was all that we got from that, that was the purpose. So that was narrative medicine.
Nice. Yeah, I can imagine that. I'd be excited about that. And I you know, I've been a teacher, and that those kind of things, yeah, float people's boats. Yeah, those definitely is collective. So you all feel like a part of this. It's not, and even if you're like uncomfortable with literacy or whatever, like one line adding to the next isn't too demanding. And yeah, I can imagine that being really, really powerful. So as we draw to a close, Eve, thank you so much for your time. By the way, if anyone has any questions, please get them in. I did want to say this, just some Eve love here. Yes, let's throw that one in. Eve Makoff is really interesting. Seems to be exactly in the right job. So you have validation there, whether you needed it or not. So that's excellent. Thank you, West 501.
Appreciate it.
So as we draw to a close, where do you see this going for you? Where do you see it going, maybe as a thing, you know, more widely? And yeah, we'll go with that.
With narrative medicine?
Yeah, narrative medicine. Mm-hmm. Where would you like to take this? You know, how do you see yourself in 5 years in terms of narrative medicine?
I would love to teach medical students. I mean, really just kind of, and I'm sure it will still, there's still people drawn to medicine who are going to be often that sort of rigid, what, I have to read a poem, you know, but using those other skills of trying to elicit why people are uncomfortable and all of that, I think that would be really, really fun. I also think about broadening that to other groups, whether it is like an eating disorders clinic or kids or young adults maybe with mental health issues, like doing some kind of reflective writing. So there are a lot of things that I think it will be those moments that happen that lead me in a direction that I don't know what they are yet.
I wonder if you'll ever get, and I'm sure you will, like big God discussions. I'm surely something that's going to come up at some point where you'll have these big existential discussions. You're like, oh, this is uncomfortable, or I don't know, or maybe really enlightening and really interesting.
I don't think any conversations make me uncomfortable anymore.
Yeah. Well, yeah, you've probably heard it all. Yeah. Is there anything that you really are hoping? I mean, you've mentioned so many times today that, oh, I'm going to write something about that. This is just this is exactly what goes on in my life, which is like every time I open I read a magazine yesterday, New Humanist. I'm like, every article I read, I've got to write an article on that. I've got to write an article on that. It's like 15 minutes into reading, and I've already got like 6 articles I have to write. I'm thinking, gee. So, you know, what are you hoping to touch on in your writing OnlySky over the next sort of few months?
Yeah, I think this topic of religion at the end of life is something we've been talking about within the group. Yeah, I mean, again, there's so many, you know, something about sort of my experience going back to school is kind of fun. And also this idea of working with people who are already formed. My challenge as a leader of doctors who are fully formed is it's really, you know, I got to take a deep breath sometimes, right? I mean, the perspective has been shut down for so many years, you know, and I try to lead by example, like, you know, in how I show up, not as sort of a traditional leader. So there's a lot in there, and I still feel like I'm learning how to write. I have to give kudos to Dale here. He's the most amazing editor.
Sorry, that's Dale McGann, who's the editor at OnlySky.
Yeah, like as an editor, he makes my voice sound better, and I learn from him. And I'm always looking for people who can help me, because I still don't feel like I get an idea. I don't know, maybe it's just painful, and that's what writing is. But I'm like, I don't always know how to get where I'm trying to go. So it's something I'm still actively working on.
I have found, for what it's worth for me, I mean, whatever, like, but I have found that the more I've written, like the better and the more comfortable I become. So now, like, I'm producing some of, in my opinion, some of the best writing I've ever produced. But that's only because partly to do with OnlySky and actually the style becoming a little bit more journalistic or a little bit more. So it was an interesting. We've been talking at OnlySky about it not being a blog. So blog is all about your in group and like I'm just writing for these people, and so then it's not lazy, but you get a bit like informal and shortcutty type writing. Whereas now this is to appeal to anyone who happens upon this piece of writing, and therefore it needs to be like intrinsically valuable. And so I don't know, I've just found that the longer I've written, the more I've written, the better you get, and B, just changing and thinking about voice and thinking about style and thinking about things like that means that just I don't know, it's all coming together. So I guess the more you do it, the better you get.
No, that's good to hear. I feel like I'm still finding my style, and I also feel like I don't want to only do one style. You know, sometimes I want to just write stream of consciousness type poetry. Sometimes I want it to be researched. And sometimes I want it to just be a personal essay. And maybe that's okay. But I wonder if people ultimately have one style. But who's to say? What are the rules, right?
Yeah, that's it. And there's a whole lot of subjectivity to all kind of creative expression. But there you go. So where can people find you? Do you want people to find you?
Sure. I'm on Twitter, at least for now.
Controversial. I appear to have become the Twitter correspondent for OnlySky because I've written like 3 articles on Twitter. But yeah, sorry.
That's appreciated. Now on OnlySky, I have a website that I just have not been able to take the time to figure out, so I don't really use it yet. But Twitter, it's Eve Louise Makoff is my Twitter handle, so pretty easy to find. So that's pretty much it. I've published in a fair number of medical journals, like a lot of reflective pieces, and I'm trying to work on a memoir. But again, starting school and working full time, we'll see where that goes.
Yeah, absolutely. Well, look, thank you so much for your time today. I've really, really appreciated it. And it's, but largely because it's such a different sort of topic. I'm normally talking about whether God exists and like philosophical wrangles about, heaven and the problem of evil. Why is there so much suffering in the world? And here we're talking about, very real suffering. And how best to deal with that, and the great value of palliative care, and hopefully, as we will hopefully see going forward, narrative medicine. So thank you very much. Are there any last things you want to say?
No, just thank you for the opportunity. It's fun to talk.
Yeah, it always is fun to talk. Well, everybody, as I always say at the end of my videos, please question everything, particularly yourselves. And thank you for hanging out and supporting the channel. Thank you for your chat at the side. It seems really great. Thank you, Melody, by the way. It seems really great that Mitch and James, talking about loneliness. Now there appears to be like a joint podcast or something going on at the side. So, wow, we've inspired some really positive outcomes here. So that's really great. Thank you, Eve. You take care, and let's all check out her work on OnlySky. Until next time, toodle pips, everybody.
Bye.